Good morning, students. Today we will see about the fistula in obstetrics. Fistula is an abnormal connection between two body parts such as organ or blood vessels or other structures. Fistula are usually the result of an injury or surgery. Infection or inflammation can also cause fistula to form. Genitourinary fistula is the abnormal communication between urinary tract and genital tract, either acquired or congenital, with the involuntary escape of urine into vagina. The types include bladder, that is vesico-vaginal, vesico-urethrovaginal, vesico-uterine, vesico-cervical. Urethra, it is urethrovaginal and ureter, uretrovaginal, uretrouterine, uretrocervical. Vesico-vaginal fistula is an abnormal opening between the bladder and vagina that results in continuous intermittent urinary incontinence. This is the commonest type of genitourinary fistula. Causes, it is obstetric. In developing countries, it is the commonest and constitute 80 to 90% of cases. That means ischemia. It results from prolonged compression effect on the bladder base between the head and symphysis pubis in obstetrical labor, which lead to ischemic necrosis, infection, slugging, fistula. So it may take few days following delivery to produce such a fistula. Traumatic, like instrumental vaginal delivery, abdominal operations such as hysterectomy for rupture of uterus or repeated LSCS. Gynecological causes include operative injury, malignancy, radiation, infective, chronic granulomas. Types depending upon the site: juxtacervical, close to the cervix, with the communication between supratrigonal region of the bladder and vagina. Mid-vaginal, communication is between the base of trigone of the bladder vagina. Juxta-urethral, the communication is between the neck of the bladder and vagina. The clinical features include patient's profile. Commonly, they are of young primiparous with a history of difficult labor or instrumental delivery. Symptoms include continuous escape of urine per vagina. This true incontinence is the classical symptom. Patient have no urge to pass urine. If the fistula is small, the escape of urine occurs in certain position. Patient pass urine normally. Flatulence, that urinary incontinence or fecal incontinence, which may be continual or only happen at night. Foul-smelling vaginal discharge, repeated vaginal or urinary tract infections, irritation or pain in the vagina or surrounding area, pain during sexual activity. Signs include vulval inspection, escape of watery discharge per vagina, of ammonia smell is characteristic, evidence of excortation of vulval skin, varying degree of perineal tear. A significant leukocytosis may be evident. Usually, fistula occur between 7th and 12th day after obstetric or gynecological surgery. The diagnosis can be established by filling the bladder with a dilute solution of methylene blue. In patients with urinary incontinence, tampon test, which is tampon inserted into the vagina after filling the bladder with solution and the patient is ambulated. It can lead to the confirmation of diagnosis. Cystoscopy is also of particular help, can clarify the exact anatomic origin. For small fistula, it may be helpful to attempt to pass a small ureteric catheter through the suspected fistula tract to determine if it enters the vagina. Further diagnostic procedures should include retrograde and voiding in the cysto-urethrography. High creatinine level of the discharge can confirm urinary leakage. However, intravenous pyelography and cystogram may not demonstrate the genital abnormalities. The advanced but more invasive and costlier technique include combined vaginoscopy. Cystoscopy also can be used. Subtraction of magnetic resonance, fistulography, and endocavitary ultrasound to the transrectal or more properly to transvaginal route with or without Doppler or contrast agent. Transvaginal sonographic evaluation can clearly visualize the exact site, size, and course of fistula. 3 swab tests. 3 cotton swabs are placed in the vagina, one at the vault, one at the middle, and one just above the introitus. Methylene blue is instilled into the bladder through a rubber catheter, and patient is asked to walk about 5 minutes. Then she asked to lie down and swabs are removed. The observation is the uppermost swab soaked with the urine but unstained with dye. Lower 2 swabs remain dry. It indicates uretrovaginal fistula. Upper and lower swabs remain dry, but the middle swab stained with dye. It indicates vesicovaginal fistula. Upper two swabs remain dry, but the lower swab stained with dye. It includes urethrovaginal fistula. Treatment. Preventive, adequate antenatal care to screen high-risk mothers prone to develop obstetrical labor. Early detection, ideal management of obstetrical labor. Continuous bladder drainage for variable period of 5 to 7 days following delivery in case of long-standing obstetrical labor. Care to avoid bladder injury during pelvic surgery. Definitive surgery include local repair by flap splitting method. Its ideal time is 3 to 6 months following delivery. Advice during discharge is to pass urine more frequently, avoid intercourse for at least 3 months, avoid pregnancy for at least 2 years. If conception occurs, mandatory checkup and successful repair should have abdominal surgery. Prescribe adequate supplementary iron and vitamins to improve the health status. If the repair fails, local repair should again attempted after 3 months. In case of repeated failure, before clearing its case as irreparable, better to have a second opinion or to consult a urologic surgeon. Urethrovaginal fistula. Part or wall of urethra is involved along with the bladder. Causes are same that of vesicovaginal fistula. Small isolated urethrovaginal fistula is caused by injury during anterior colporrhaphy, urethroplasty, suspension or sling operation for stress incontinence. Residual fistula left behind following repair of vesico-urethral. Diagnosis. Patient have an urge to pass, but the urine dribbles out into the vagina during the act of maturation. A metal catheter passes through the external urethral meatus, which when comes out through the communicating urethrovaginal opening confirms the diagnosis. The treatment includes surgical repair in 2 layers followed by continuous bladder drainage as outlined in repair of vesicovaginal fistula is satisfactory. Urethrovaginal fistula causes acquired, that is common, follows a trauma during pelvic difficult surgery like abdominal hysterectomy in cervical fibroid, broad ligament fibroid, etc. and the congenital. Rectovaginal fistula, abnormal connection between the rectum and the vagina with involuntary flatus or into the vagina, causes acquired obstetrical. It may be because of the obstetrical labor. If the sacrum is flat during the obstetrical labor, the compression effect produces pressure necrosis, infection and slugging of fistula. Instrumental injury during destructive operation. Gynecological include fall on a sharp pointed object. Malignancy of vagina is the most common cause. Cervix or bowel, radiation, TB of vagina, diverticulitis of sigmoid colon and Crohn's disease. Diagnosis. Involuntary escape of flatus or feces into the vagina. Rectovaginal examination shows the site and size of fistula. If a small conformation is done by probe passing through the vagina into the rectum. Treatment. Preventive include good prenatal care, consciousness about possible injury to the rectum during gynecological surgery. Definitive surgery include if it is situated low down to make it complete perineal tear and then repair. Situated in the middle third, repair by a flap method. Situated high up as a preliminary colostomy, then local repair after 3 weeks, closure of colostomy then after 3 weeks. Thank you for listening. If you have any doubts,